Welcome to the deep dive. Today, we're tackling a global health topic that is, well, it's incredibly common and frankly a little upsetting. We're talking about helminthic infections.
Harms.
Yep, worms. And this isn't some distant issue. We're talking about something that affects roughly 1 billion people across the globe, with frequent outbreaks right here in the US and Canada.
Exactly. And while the diagnosis can be psychologically, very difficult for a patient to accept, the clinical reality is that it demands swift, precise action.
Okay.
So our mission today is to distill the essential pharmacology and nursing knowledge around what we call anthelmintic agents. We're going to focus on identification, the treatments, and critically, the safety and public health steps that make or break a successful eradication.
All right, so let's start with the cast of characters. We need to know who we're treating. A helminth is the general term for a parasitic worm. Our sources break them down into two major groups. First, you've got the nematodes. These are your roundworms, which include really common ones like pinworm. Then second, you have the platyhelminths.
The flatworms. The flatworms, exactly. So flukes and tapeworms. The goal for you, listening, is to understand that the specificity of the diagnosis is everything. It absolutely dictates the choice of treatment.
To really emphasize that point, you cannot treat what you haven't specifically identified. A proper diagnosis for any of these infections requires lab work.
A stool sample.
Specifically, a stool examination for ova, that's eggs and parasites. These drugs are way too targeted, and some are just too toxic to simply guess.
Let's start with the nematodes, the roundworms, because honestly, their life cycles are wild. The most prevalent one worldwide is Ascaris. So you ingest the eggs, but here's the key clinical phase. After they hatch, the larvae, they migrate through the body. They actually go to the lungs.
Right, which is so counterintuitive.
It is. And it causes symptoms that look just like pneumonia. You get a cough, fever, a pulmonary infiltrate on an x-ray. So it presents as a respiratory issue first. And only after that do they return to the small intestine where they mature into these large adult worms. That's when you finally see the GI symptoms, the abdominal pain, distension, and the really dangerous part, a potential intestinal obstruction from just a tangled ball of worms.
Then you've got the much more localized, common one, pinworm. This is the one every school nurse knows about.
Oh, yes.
Most common in U.S. school-aged kids. Transmission is so easy the eggs can be airborne, or you can get them just from touching contaminated surfaces, clothing, bedding.
And they stay put in the intestine, causing that intense perianal or vaginal itching. That's because the female worms migrate out at night to lay their eggs.
And we have to talk about the really damaging hookworms. These larvae are true travelers. They penetrate the skin.
Right, usually when someone walks barefoot on contaminated soil.
They get in, travel to the intestine, attach to the wall, and actively suck blood. This leads to profound blood loss. We're talking severe anemia, lethargy, weakness,
And serious malabsorption issues. I mean, treating the anemia often becomes just as critical as actually treating the worm itself.
So, moving beyond the gut, we get to the really serious ones, the tissue invaders. These are so much harder to manage because they leave the GI tract and go systemic.
Yeah, this is where it gets scary.
Take trichinosis, for instance. This comes from ingesting encysted larvae in undercooked pork.
And those larvae don't stay in the gut at all. They invade crucial structures. Skeletal muscles, nerves, the heart, even the brain.
The consequences are, they can be catastrophic: fatal pneumonia, heart failure, or severe encephalitis.
Which really highlights a key point. The best treatment for trichinosis is prevention. It's all about proper cooking and freezing of pork, because once those larvae are encysted in your tissue, treatment is incredibly difficult and, frankly, often ineffective.
And finally, there's the flatworm schistosomiasis, or snail fever. This is a huge issue in tropical areas, the Nile River, parts of Africa, Asia, the Caribbean. The parasite is carried by a snail, which releases larvae into fresh water.
And if you wade or swim in that contaminated water, the larvae just burrow right into your skin. The first sign might be something called swimmer's itch.
From there, they migrate to the liver and the bladder, causing chronic diarrhea and potentially leading to massive enlargement of the liver and spleen hepatosplenomegaly.
So for travelers going to these areas, this is our critical cultural and safety consideration. Do not wade, swim, or bathe in local freshwater sources. That warning has to be explicit.
Since identifying the exact culprit is so important, let's look at the pharmacological arsenal. The treatment has to be just as specific as the diagnosis, right?
Absolutely. The class of drugs, anthelmintics, they're highly specialized. They're not interchangeable. Their whole effectiveness relies on targeting a metabolic pathway in the worm that is either totally absent or structurally very different in the human host.
It's like a lock and key.
It really is a keyhole surgery approach to pharmacology.
So we have 5 major players here: albendazole, ivermectin, mebendazole, praziquantel, and pyrantel. Let's try to visualize how they work, because they operate on, 5 completely different principles.
Okay, let's start with mebendazole. It's the prototype drug for a lot of these gut infections. Its mechanism is so effective, it irreversibly blocks the worm's ability to take up glucose.
So it cuts off its fuel line.
Exactly. You're starving it. No glucose means glycogen depletion, no energy, and eventual cell death.
Okay, and albendazole uses more of a structural attack. It blocks something called tubule formation.
Right, and the tubule structure is fundamental for the worm to maintain its cell structure. Blocking it effectively causes the cell to collapse and die.
Then you have ivermectin and pyrantel, which are all about paralyzing the worm.
Correct. Ivermectin blocks calcium channels, which results in nerve and muscle paralysis. Pyrantel is what's called a neuromuscular polarizing agent, which also leads to paralysis and death.
And if the worm is paralyzed, it just loses its grip and gets expelled.
That's the idea.
And then there's praziquantel, which is mostly for flatworms like schistosomiasis. This one sounds dramatic. It uses a kind of chemical shock.
It does. It dramatically increases the worm's membrane permeability. This causes a huge loss of intracellular calcium, leading to muscular paralysis, and even more intensely, it can cause the worm's outer layer, its integument, to just disintegrate.
So it basically causes the worm to leak itself apart.
In a way, yes. It's incredibly effective.
Yeah.
Now, connecting those actions to the patient's experience is crucial. There's a huge trade-off between local and systemic drugs.
What do you mean?
Well, mebendazole and pyrantel are poorly absorbed. They pretty much stay in the GI tract. So their side effects are usually mild and local, some abdominal discomfort, maybe diarrhea.
Okay, that makes sense.
But the other 3, albendazole, ivermectin, and praziquantel, they are absorbed and metabolized by the liver. When they kill a systemic worm, the patient's body mounts an immune reaction to all the dying organisms.
So you're not just feeling the drug, you're feeling the die-off.
Exactly. And that means more severe systemic adverse effects. Headache, fever, shaking chills, just a general feeling of malaise. It's basically an inflammatory response to the war being fought inside the body.
Given those systemic effects and potential toxicities, safety must be paramount.
Oh, absolutely. The contraindications are critical. Known allergy, of course. Lactation women must refrain from breastfeeding. And very importantly, pregnancy.
Right.
Many of these agents have been linked to fetal abnormalities or even death. So women of childbearing age must use barrier contraceptives all through therapy.
And we need to talk about the unique toxicity risks, especially with albendazole. This drug is highly potent, and it requires really close monitoring for severe bone marrow depression and possible renal failure.
And its effects are increased if you combine it with certain drugs like dexamethasone or cimetidine, which forces you to monitor the patient even more closely.
So why do we use it if it's so risky?
Well, that's the insight, isn't it? We tolerate that high risk with albendazole because the consequences of not treating a deep tissue-invading parasite like trichinosis are so much worse than the side effect profile. It's a risk calculation.
Got it. And what about praziquantel dosing?
Good point. It's rapid acting, but it often needs 3 separate oral doses spaced about 4 to 6 hours apart, just to make sure you get complete coverage.
And how does treatment change across a lifespan? For kids, for example.
For children, we definitely try to avoid the more toxic systemic drugs like albendazole and ivermectin. Mebendazole is often preferred, and it even comes as a chewable tablet.
And I imagine monitoring nutrition and hydration is key, especially if they have bad GI distress.
It's a top nursing priority. And the same goes for older adults. They're generally more susceptible to the CNS and GI effects, so they need dose adjustments and that same constant monitoring of their nutrition and hydration.
And this brings us back to the psychological piece we mentioned at the start. For any adult, a diagnosis of a worm infestation can feel just profoundly invasive, repulsing even.
It really can. And our role has to shift from just dispensing meds to providing really strong emotional support and reassurance. Helping them cope with the diagnosis is key to them actually sticking with the rigorous treatment.
So the clinical treatment is only half the battle.
Not even half. Eradication hinges entirely on the patient adhering to strict non-drug interventions and hygiene. Let's use the pinworm example as a case study because it's so contagious.
Okay, so when we're teaching the patient and their family, we have to be incredibly detailed. First, you have to trim fingernails short. That's to prevent eggs from transferring from the anus to the mouth.
So simple, so important.
Second, we recommend showering and not bathing in the morning. Why the morning? Because it washes away the ova that were deposited around the anus during the night.
And the cleaning regimen has to be aggressive. You have to launder undergarments, pajamas, and all bed linens daily. And in hot water, preferably with chlorine bleach.
Daily disinfection of the toilet seat, too. It's non-negotiable if you want to break that cycle of reinfection and spread.
And if you skip any of those steps, the treatment is very likely to fail. The drugs alone aren't enough.
Right. And beyond hygiene, there's patient safety. If a patient is taking a drug like praziquantel, which has risks of dizziness or drowsiness,
The CNS effects.
right, we have to implement safety precautions. We're talking educating them to change positions slowly, assisting with walking, maybe using side rails, and strictly advising them to avoid driving or operating machinery until those effects are gone.
And this all wraps up with the need for sensitivity, especially when there are language or cultural barriers.
Yeah.
If you're instructing a patient who might have schistosomiasis and, has limited language ability, just talking at them won't work.
You have to get creative.
You do. Nurses have to use pictures, calendars, clocks, whatever it takes to make sure they understand the medication times and the hygiene schedules. Clear communication combined with real empathy ensures the patient gets that while this is serious, it's also common and absolutely treatable.
So, to summarize our deep dive, these helminthic infections are a massive global health issue that demand precision. Treatment requires these highly specific anthelmintic drugs that attack the worm's unique metabolism.
Mhm.
But what we've really learned is that the ultimate measure of success, the one factor that prevents reinfection, relies entirely on the patient's rigorous, non-negotiable adherence to public health and hygiene practices at home.
Exactly. And that leads us to a final thought for you to carry forward. When you are delivering the instruction for daily laundering, toilet disinfection, and morning showers to a patient just diagnosed with worms, you are confronting a very real, deep-seated psychological distress. So how do you, as a healthcare provider, balance the absolute clinical necessity of delivering those strict, detailed instructions with a profound human need to alleviate that patient's shame, their fear, and their anxiety? That balance of clinical rigor and profound empathy is really the ultimate measure of nursing success in this field.